Dr. Raymar Sibonga. He is an associate professor at the De La Salle University Health Science Institute. He is also the current head of the section of hand and reconstructive microsurgery of the Department of Orthopedics of De La Salle University Medical Center, and is also the part of the board of editors in the Asia Pacific Federation of Societies for Surgery of the Hand newsletter. Our second speaker is Dr. David Alagar. He is the current vice president of the Philippine Orthopedic Association. He graduated from the University of Santo Tomas Faculty of Medicine and Surgery and subsequently took his orthopedic residency at the Philippine Orthopedic Center. He is a past president of the Association of Hand Surgeons of the Philippines, an international member of the American Society for Surgery of the Hand, and is also the head of the hand surgery unit of the Philippine Orthopedic Center. Our third speaker is Dr. Henry Gerard Calleja. He graduated from St. Luke's College of Medicine and took his orthopedic residency training at the St. Luke's Medical Center Institute of Orthopedics and Sports Medicine. He also took his fellowship in hand and microsurgery at the Kleinert Institute at the University of Louisville in Kentucky, USA. He has several international publications and is also an international member of the American Society for Surgery of the Hand. He presently serves as the head of the training and research committees of the Institute of Orthopedics and Sports Medicine of St. Luke's Medical Center. Our final speaker for the case presentation this afternoon will be a first-year resident from De La Salle University Medical Center, Dr. Kerwin de la Cruz. Okay, so I think we can now start with the first lecture of Dr. Sibonga on Wallant for upper extremity fracture fixation, a pandemic local experience, to be followed by Dr. Alagar's lecture on management of neglected flexor tendon injury, and finally, Dr. Calleja's lecture on distal radius malunion.
Good day, everyone. My name is Raymar Sibonga. I am a hand surgeon, and I will be talking about Wallant for upper extremity fracture fixation, our pandemic local experience. I received no monetary compensation or any sort from the originators of this technique, as well as the book and medications being presented in this lecture. This will be the outline of my talk, and later I will be showing you some sample cases relevant to our topic. So what is Wallant? Wallant is an acronym that stands for Wide Awake Local Anesthesia, No Tourniquet. Two medications are given to the patient as cocktail: lidocaine for anesthesia and epinephrine for hemostasis. Sodium bicarbonate, if readily available, can be given within the cocktail to decrease injection pain by increasing the pH of the solution. Together, they act as a form of an extravascular beer block to the site of surgery, negating the need for the use of a tourniquet in a wide-awake patient. A little bit about the history of Wallant in hand surgery. Procaine was the first widely used local anesthesia in the early 1900s. When mixed with epinephrine, it can result to finger necrosis when given to terminal arterial branches, giving rise to the epinephrine myth. Lidocaine came to use in 1948. With the discovery of lidocaine, some doctors showed no finger necrosis when lidocaine plus epinephrine cocktail was used on the finger. Furthermore, in 2001, Donald Lalonde introduced field-sterile Wallant for minor soft tissue surgeries of the hand and wrist, and later published the multi-center study called the Dalhousie Project, comprised of 9 surgeons in 6 cities, where they showed no finger necrosis in 3,110 subjects, where they performed Wallant in the hand and or the fingers. In 2016, he published his book entitled Wide Awake Hand Surgery and became the reference for Wallant surgery worldwide. Truly, we are standing on the shoulder of giants, as some surgeons expanded the use of wide-awake surgery, not only to soft tissue surgeries of the hand and wrist, but also to bone fixation of the extremity. Dr. Amir Ahmad from Malaysia published his work last June 2018 in the JHS American volume on the use of Wallant for distal radius fracture fixation. This has been adopted by surgeons all over the world, and we were lucky to hear it directly from the man himself when he accepted to be our speaker last July 29, 2020 via a joint online activity of the POA and the Association of Hand Surgeons of the Philippines. Fast forward to my first Wallant case for bone fixation of the upper extremity in one of the tertiary hospitals in Quezon City, Philippines. We did a distal radius fracture fixation last December 4, 2020 to one of the patients who is keen to be done under Wallant because he cannot wait for an elective schedule after the anesthesia annual convention. And the rest just snowballed from there. These are some videos of patients under Wallant after fixation from left to right, your metacarpal fracture fixation, your distal radius fracture fixation, and your radial shaft fracture fixation. As of present, I have done or have been involved in 73 bone fixation done under Wallant. Wallant has come a long way from soft tissue surgeries to bony fracture fixation. Expansion of bony Wallant started from the phalanges and the metacarpal, distal radius, isolated ulna and isolated radial shaft fractures, as well as both bone deficial forearm fractures. And who knows what's next and how proximal we can go in the upper extremity. Amir Ahmad and group published their study on the official plating of forearm fractures under Wallant last February 2022. However, they excluded segmental injuries in their population. And for further pushing our indications, we attempted doing Wallant on a patient with a segmental injury of the radius with concomitant ulnar shaft fracture with success. And it is always a good feeling when your work gets acknowledged by the innovating surgeon himself. So why Wallant? Wallant because it is cheaper. It is done under local anesthesia. It is done as a day surgery case, so there's no need for admission. There's no need to wait for an available bed. There's no need to put patient on NPO. Training hospitals with training residents can continue doing major upper extremity fixation to ease out issues regarding decreasing number of surgical cases. It is safe because actually the best sedation is no sedation. It is a non-aerosol generating procedure and the patient can wear mask during the surgery. Fixation can be tested for stability intra-op. It is actually easy as it is highly successful even on your first try. And it requires less manpower, no need for manongs and nurses for PACO monitoring, and no need to wait for an available tourniquet before your surgery. We now go to the most important part of the lecture, to which I think would be relevant to our practice in any case we contemplate on doing Wallant. Basically, you need to make a cocktail of 1% lidocaine in 1:100,000 epinephrine as recommended by Donald Lalonde. We don't usually have the pre-mixed lidocaine plus 1:100,000 epinephrine dental preparation on our operating room. And worldwide, there are different preparations of lidocaine and epinephrine. We will focus on what is readily available locally at any hospital in our country and need to make do with what we usually have, which are your 2% lidocaine containing 20 milligrams per ml in 5 ml carpule and 1 ml epinephrine in 1:1,000 preparations along with your normal saline preparations. The recommended safe dose of your epinephrine and lidocaine cocktail is 7 milligrams per kilo. So a 2% lidocaine with 20 milligrams per ml in 5 ml carpule will roughly contain 100 milligrams of lidocaine per carpule. An average 70 kilogram person will maximally need 490 milligrams of lidocaine, which is approximately 5 carpules of this preparation. I don't want to bore you with the numbers and computations, so I will just show you. This is a modification of Marco Felipe from Basil's preparation in simple form. So how do you make 2% lidocaine into 1% with 1:100,000 epinephrine dilution? So basically 5 cc's of 2% lidocaine, you add 5 cc's or dilute it with 5 cc's of normal saline to make 10 cc's of 1% lidocaine. You add 0.1 ml of your 1:1,000 epinephrine preparation to make your 10.1 ml of Wallant solution. As shown on the video, again, 5 cc's of lidocaine, dilute with equal amounts of normal saline, and add your 0.1 ml of epinephrine 1:1,000 preparation. If you have sodium bicarbonate available, you can add 1 ml per 10.1 cc of solution to make 11.1 ml of your Wallant solution. So how to inject? You start by making a disturbance around the first injection site by pinching the skin. Use gauge 27 or 30 needles. First injection should be perpendicular to the extremity. After giving 2 cc's of solution, you can reposition the needle parallel or at an angle to the extremity. You need to feel for the tumescence. You need to blow slow before you go. Advance as needed with the needle prick proximal to 1 centimeter of the tumescence. For periosteal block, you can give it on the palmar as well as on the dorsal side of the bone through your superficial bony surfaces. As long as you are within the recommended dose, too much local anesthesia is better than not enough local anesthesia. This is the desired effect after infiltration of Wallant solution, showing you the borders of the tumescence and the blanching effect of the epinephrine. For distal radius fracture fixation, reserve your last 10 cc's of Wallant solution for pronator quadratus infiltration during your deeper dissection. Some tips in pearls when doing Wallant surgery for the upper extremity. You need to free up the elbow 1 to 2 days prior to the surgery. You would want your patient to reposition their wrist and hand comfortably on the OR table while you are giving your Wallant solution. Music in the OR calms the patient before you start the procedure, especially if it is their jam that is being played. This is where your Spotify come in handy. Start your surgery at a minimum of 26 minutes, as this is the average take of epinephrine vasoconstriction. Give it before doing your ortho prep, your ortho scrub, draping the patient, and please do a complete timeout with prayer so you don't feel the weight. Talk to the patient, check on them once in a while. You can give post-operative reminders and instructions during surgery. This makes patient comfortable knowing they can have an open communication with you. And lastly, never ever say oops or I during the surgery. This gives patient an impression that something bad is happening and it doesn't help. If you need to correct something, do it with eye contact or simple hand gestures. I just wanted to show you some local trends. When you compare peripheral nerve block versus Wallant, it has been shown that locally, Wallant has significantly lower VAS scores post-operatively when compared to your peripheral nerve block. In terms of material costs, Wallant has been shown to have material costs which is 32% cheaper than general anesthesia and 22% cheaper when compared to your peripheral nerve block. In terms of peri and post-operative outcomes of the procedures done under Wallant, it has been shown to have comparable results than those done within peripheral nerve block or general anesthesia. So in summary, Wallant has a proven track record for bone fixation surgery of the upper extremity, which is safe and effective. It is easy to perform even on your first try, and it is an added armamentarium for more flexible options that can be titrated according to your patient needs or wants. Sharing to you my own realization in this changing time amidst this COVID-19 pandemic before I end my talk. We can always stay within the borders of our comfort zone, but sometimes we can break through those borders and still be comfortable outside it. Thank you very much, and I hope you learned something from this talk.
Good morning. Let me share with you this case. A student cut his right hand while breaking an ice block 2 years ago. As a result, he cannot flex both the ring and small fingers. Only flashing and suturing were done at the ER then. He was not able to return for fear of getting the COVID. Only when things got better was he able to visit 8 months later. Hi, I am Dr. David Alagar, and I will be talking on the management of neglected flexor tendon injury, Zone 2, in the Twilight Zone. If you are not familiar with the TV series, The Twilight Zone, it tells of weird stories, a strange mix of horror, science fiction, drama, comedy, and superstition, with surprise ending. Sadly, stories of outcome after treatment for neglected Zone 2 injuries were described similarly. I have no financial disclosure for this lecture. Over the past half century, there have been dramatic improvements in primary flexor tendon repair. This resulted to good outcome and less need for flexor tendon reconstruction. Unless, of course, you have a crushing, contaminated, and complex injury or a neglected case. Reconstruction of flexor tendons remains a challenging task. The problem with neglected cases are the tendons are shortened with significant gap, and the sheaths are collapsed, and the tendon bed scarred. The concept of treatment, therefore, is to restore the continuity of the tendon. So we must bridge the gap and ensure a flexor sheath that will maintain the tendon close to the bone, allowing good excursion and avoiding adhesion formation. Injured flexor tendons are graded according to severity. The higher the grade, the worse the condition is, the poorer the outcome. The standard treatment for this injury is a two-stage reconstruction. The first stage consists of removing all tendon remnants, placing an artificial tendon, and doing an annular ligament reconstruction. After 3 months, the second stage is performed, removing the artificial tendon and replacing it with a tendon graft. A Brunner incision is ideal. All injured tendon remnants are removed in the tunnel, but a good amount of distal FDP stump is left for securing the new tendon. The artificial tendon is secured distally. This can span the fingertip to the forearm or only until the palm, depending on the amount of damage and the surgeon's preference. While waiting for the next stage, regular passive flexion and extension of the finger is undertaken to keep the joint supple and to stimulate the pseudo-sheath formation. On the third month, the second procedure is performed. Smaller incisions are made to visualize the silastic rod proximally and distally. At the same time, graft harvest is done, usually the palmaris longus tendon of the same arm. The attachment of the artificial tendon to the distal FDP stump is released and replaced by one end of the harvested tendon. The other end of the tendon is then sutured to the silastic rod and pulled into the tunnel by the rod as it is pulled out through the palmar incision. Once the graft is passed proximally, it is secured to the proximal end of the injured FDP tendon or to an adjacent profundus tendon in the distal forearm. Securing the graft proximally is achieved using the Pulver-Taft technique. And since the patient most often is sedated or had a regional block, only the passive flexion extension maneuver can demonstrate the integrity of the reconstructed tendon with the tenodesis effect. Alternatives to the hard-to-find silastic rods include the following. These are the frugal innovations mostly used in India, but I personally prefer to just regas the previously used rods when stocks ran out. And so far, I have not seen any problem coming out from it, nor have I seen studies about this practice. Now let me share some cases we saw these past 2 years. Here's an accountant who accidentally cut his dominant hand while preparing food. He sustained a flexor tendon injury to his index, middle, ring, and small fingers. He is unable to flex his index DIPJ and both PIPJ and DIPJ for the long ring and the small fingers. Surgery was only scheduled 9 months after. It was decided to just fix the long ring and small fingers and leave the index finger since the FDS allows PIPJ flexion. So he underwent the Hunter-Salisbury reconstruction under regional block. Tendon remnants were excised, silastic rods placed, sheath reconstructed, and closed. 3 months later, he underwent the second stage. So we used the palmaris longus tendons for both hands for the 3 fingers. 7 months after, here he is and at work. Despite its effectiveness, there are still criticisms to this technique. One issue is it uses an extra synovial graft, meaning different from the injured synovium covered tendons. Two, because the graft is yet to be harvested, it is difficult to estimate the ideal rod size to use in the first stage, making a possible tendon tunnel size mismatch on the second stage. And three, the proximal stump of the injured tendon is difficult to retrieve by the time of the second stage due to the tendon retraction. Because of this, others prefer the combined Hunter and Paneva-Holevich technique. In the Paneva-Holevich procedure, the proximal ends of both FDP and FDS tendons of the injured finger are loop sutured together in the first stage, so that in the second stage, when the tendons have healed, you can just cut the FDS component more proximally, pull and secure it to the proximal end of the silastic rod, and tunnel it through the sheath as you pull out the rod distally in the fingertip incision. Here's an example of that procedure done last year. A policeman cut his dominant index finger as he held onto a broken glass. Surgery was scheduled 3 months later, under warrant as an outpatient procedure. So the cut ends of the FDP and FDS of the injured index finger were sutured together and the silicone rod secured in the FDP insertion distally. 4 months later, the FDP-FDS junction has healed. The FDS was cut proximally and pulled out in the palmar incision and tunneled into the flexor sheath using the silastic rod as carrier. This time, tendon graft tensioning is done distally while suturing to the FDP stump. Once able to get the right finger cascade, this is secured. And here is the patient 5 months later, able to use his injured finger to pull the trigger once more. Other reported alternatives to the two-stage reconstruction include the use of an active tendon prosthesis, which permanently bridges the gap and replaces the distal segment of the injured tendon. The other is the single-stage vascularized flexor tendon transfer, which transposes a segment of the FDS tendon from another finger with mesotenon, therefore using a more compatible graft. So what happened to our index case? 8 months after the injury, under regional block, we did the combined Hunter and Paneva-Holevich technique. So we took out the tendon remnants, loop sutured the proximal ends of the tendons in both injured fingers, inserted the silicone rod, and reconstructed the flexor sheath. After 4 months, did the second stage under Wallat. The FDS tendon of the involved fingers were cut more proximal, delivered into the palmar incision, and used the silicone as carrier through the tunnel. Here is the graft tension trial for the ring finger and the final outcome after securing the small finger. Graft tensioning under Wallant allows you to achieve a more anatomic finger cascade. Here's the patient at 4 months and at work fixing his bike. And here he is recently able to use his ring and small fingers to get a good grip of his bike as he performs this wonderful stance. The two-stage flexor tendon reconstruction remains to be a good option for neglected zone 2 injury and failed repair. Just ensure that you have a supple and sensate finger. The surgical technique is simple and straightforward. Thank you for listening.
Greetings, everyone. I'm Dr. Henry Calleja, and we will talk about distal radius malunions. Distal radius fractures comprise 12 to 17% of all fractures, with distal radius malunions developing in 24% of patients treated with a cast and 4 to 11% of patients treated with fixation. Luckily, not all are symptomatic, but when symptomatic, results in considerable disability. It can be extra or intra-articular. Displacement is always in 3 planes. Always assess radial inclination, height, or a positive ulnar variance in the coronal plane. In the sagittal plane, assess for dorsal angulation or loss of volar tilt. In the axial plane, rotational deformities can be best seen with a CT scan. There's no standard definition for distal radius malunions. The AAOS put it as post-reduction dorsal tilt of more than 10 degrees, radial shortening of more than 3 millimeters, and an intra-articular displacement of more than 2 millimeters. When these parameters are met, surgical intervention should be discussed. According to Ali et al. And Chung et al. In 2 different papers, a dorsal tilt of more than 10 to 20 degrees, radial height of less than 10 millimeters, radial inclination of less than 10 to 15 degrees, and a positive ulnar variance of more than 2 to 3 millimeters is already considered a distal radius malunion. Biomechanics whenever you have distal radius malunions. When there's a decreased radial inclination, there will be a change in direction of the flexor tendons, leading to decreased mechanical advantage and can cause hand weakness. Changes in volar tilt causes incongruity in the DRUJ and carpal instabilities. When there is a loss of volar tilt, there will be limitation in flexion and supination, and when there's increase in volar tilt, it limits extension and pronation. With radial shortening, there will be a 42% increase in the force borne by the ulna, with 2.5 cm shortening of the distal radius. The soft tissue becomes tighter, leading to loss of pronosupination also. So this is what you expect with the patient with the distal radius malunion. With severe ulnar shortening, you will appreciate ulnar head prominence and a radially deviated wrist. For a dorsally angulated malunion, which is the more common malunion of the distal radius, there will be more limitation in supination as mentioned earlier. And eventually, there will be carpal instability adaptive, as seen here, which produces a limitation in flexion of the wrist. Indication and timing of surgery. We should always consider function, pain, loss of mobility, and age should be considered in a shared decision making. No optimal timing, but according to Jupiter and Ring, earlier reconstruction is technically easier and overall period of disability is shortened. Surgery as soon as possible when malunion is noted according to Chung et al. Osteotomy techniques. There's the closing wedge osteotomy. It offers the advantage of bone-on-bone contact but produces significant radial shortening. You will often need to touch the ulna and do an ulnar shortening also in the ulna. For the opening wedge osteotomies, there's the dorsal approach. It offers technical ease, but disadvantage of extensor tendon irritation and rupture due to the plate prominence. So it has lost its favor nowadays. The more common approach nowadays is the volar approach, which allows you to use the volar locking plate, which is stronger. For the bone grafts, whenever you do the osteotomy and there's still volar cortical contact, it is suggested that you can use a minimal bone graft, which is often non-structural. But once you do your osteotomy and there's no volar cortical contact, a structural bone graft is recommended. For an osteotomy without cortical contact after correction, and you still choose a non-structural bone graft as advocated by some authors, a delay in ROM to decrease the risk for construct failure due to the reliance of support to the implant. So we have this case of a distal radius malunion, both in the coronal and sagittal plane, more severe in the sagittal plane. Patient 1 is at 6 weeks and patient 2 is at 7 weeks. Some would still consider this as a nascent malunion. So my preference for these cases is still try to look for the fracture line and do an osteotomy using osteotome parallel to the articular surface. Once the osteotomy is completed, I check for reduction. And what's important is to check if there's anterior cortical contact. And if you're happy with the radial parameters, If there's still anterior cortical contact, we decide to use a non-structural bone graft rather than a structural bone graft. So my preference here for bone graft is still an iliac bone graft using a Jamshidi needle, using a minimally invasive technique. This produces nice corticocancellous cylinders, which you can then pack in the defect, but you can still always use an artificial bone graft as advocated by some authors. Once you have packed the bone grafts in the defect, you can proceed with reduction and plating. And here's the patient 3 months post-op, showing good reduction and good incorporation of the graft in the patient with a good range of motion. But what do we do with patients with more severe deformities, both in the coronal and sagittal plane? Here we see two patients with severe loss of radial height, radial inclination, a positive ulnar variance of positive 5 millimeters and positive 7 millimeters. So we came up with a technique and published the paper last year in the Techniques in Hand and Upper Extremity Surgery. So our technique consists of we template our distal radius malunions both in the AP and lateral radiographs. We use the FCR approach and cut the brachioradialis routinely. Our first bone cut is parallel to the articular surface in both the coronal and sagittal plane. The second bone cut is perpendicular to the long axis of the radius in the lateral view. We use a lamina spreader and check reduction. We release the dorsal periosteum if the parameters are still inadequate. We apply a rectangular shaped bone graft and then plate. We repair the pronator quadratus. And take note that always be ready and consent for a possible ulnar shortening in case the reduction is still inadequate. So templating, we always template our patients so you know the bone graft, the bone gap, so you know the bone graft, that how big the bone graft that you're gonna get from the iliac crest. So these are the two osteotomies. The first osteotomy is parallel to the articular surface, both in the coronal and sagittal plane. The second bone cut is perpendicular to the radial shaft. You will get a triangular bone fragment which you're gonna remove. You can use as a bone graft later, and then you create a gap in between the distal and proximal fragments. We then use a lamina spreader and check for reduction. If still inadequate, we elevate the posterior periosteum, and you can open the lamina spreader more once the posterior periosteum is elevated. If you feel that the reduction is adequate, you measure the size for the bone graft. You can put the bone graft first, or you can plate first, then bone graft. Once the bone graft is in, the screws are placed, the graft is impacted in the ideal position, and this is the final construct. So this is the patient earlier with the severe loss of radial height, radial inclination, and a positive ulnar variance of positive 7 millimeters, a dorsal inclination of 27.5 degrees. Immediately post-op, we restored the radial height to 12 millimeters, radial inclination to 22, ulnar variance of negative 1 millimeter, and the volar tilt was restored to normal. At 3 months post-operative, you can see good graft incorporation and no loss of reduction. I always try to repair the pronator quadratus to protect the FPL from the plate. Since we routinely cut the brachioradialis, I repair the pronator quadratus to the distal cut part of the brachioradialis. So in our paper, there were 13 cases. Radial inclination was restored in 92% of the cases. Radial height was restored in all 13 cases. Ulnar variance was restored in 85% of the cases. Volar tilt was the least restored parameter at 69%. However, all improved when compared with their preoperative measurements. All cases were able to demonstrate improvement of functional outcomes from their preoperative and postoperative DASH scores. All cases had improvement in ROM, and all cases successfully concluded in radiographic and clinical union. This is one of our case, JQ, 49-year-old male, 3 months post-operatively, showing adequate range of motion and improvement in his DASH scores. So in summary, for distal radius malunion, treatment must be tailored to the individual patient. Activity and demand should play a key role in the shared decision making. When corrective osteotomy is indicated, earlier intervention is better. Plan and template the osteotomy. Use angular stable implants such as a volar locking plate. With cortical contact, you may not need a structural bone graft. For osteotomies without cortical contact, a structural graft is recommended. And always be ready and consent for a possible ulnar shortening. Thank you and good day.
For those three very informative lectures. So I'd like to welcome our three lecturers, Dr. Alagar, Dr. Sibonga, and Dr. Calleja. Good afternoon. So I'd like to start the ball rolling by asking maybe Dr. Sibonga first regarding his lecture on Wallant. As Wallant is obviously very effective during surgery in anesthetic coverage, no? Do you still subject patients, especially for major surgeries of the upper extremity, to general anesthesia or sedation intraoperatively? And can you also describe your post-operative strategies in controlling pain once anesthesia wears off in the recovery room?
Okay. So yes, to answer the question, yes, you may, if you want to subject your patient under sedation or anesthesia, even doing Wallant. So there's actually a technique, they just call it LANT, no, without WNA. So it's a local anesthesia, no tourniquet, just to still take advantage of the hemostatic effect of the epinephrine, negating the need for the tourniquet use, which, as we all know, can be a source of pain post-operatively. In Wallant patient, they don't usually stay long in the PACO, or they actually never stay in the PACO because they usually go home directly, and even before the anesthesia wears off. No, actually, there's a local RCT done in Viluna, which was presented earlier in our RRF, Residence Research Forum, and they showed significantly lower pain scale at 8 hours, 24 hours, and 48 hours when compared to PNV. Give enough time, no, for the bridging and the saturation of oral analgesia in the bloodstream.
Thank you very much. Dr. Brito, you have a question?
Yeah. Hi, Raymar. Very good lecture. In your studies, would you or have you tried fixing cases of a neglected or malunited fracture under Wallant? If so, are there any extra preparations or protocols that you would consider before doing this under Wallant surgery?
Okay. So to answer that question, for malunion, yes, I have tried, but I have to caution, no, first-time users of Wallant that neglected malunited fractures are not actually good cases, no, on first attempt, because of the myostatic contractures that starts to set in at 3 weeks down the line. So, however, in selected cases like distal radius fractures, once you get the hang and feel of doing Wallant, especially for malunion of partial articular fractures, this can be easily done even under Wallant, no? And preparations, I think, for this doable malunion, especially for nascent malunions, where you can still see the fracture line on the latest X-ray, you can attempt on doing it Wallant and just tell the patient that if he or she cannot tolerate the procedure, you can always close up the wound and schedule for another surgery under anesthesia. Or for those malunions which you think are difficult, especially when it's more than 3 months, as the cases being shown by Dr. Calleja, then the better preparation is to have the patient or with an anesthesiologist on by when you attempt on doing these types of malunion.
Okay, thank you, Dr. Sibonga. Now we'll go to the second speaker, Dr. Alagar. You already presented, Dr. Alagar, the different alternatives. Now, if the Hunter rod is not available, are these other options for like the feeding tube, the NGT, are they as equally effective with treating this kind of problem?
Thank you, JJ. If you look at the studies that presented these cases, they show that they are comparable to function, with the Hunter rods. But they also disclose that since most of these are hollow and perforated, they are not as strong as a solid a rod as in hunter, and there is the chance that you won't get a smooth bed because of the perforation. Some of the soft tissue go inside the lumen, and once you take it out, you have some spicules. So it's rough, and there are times also that there are fluid, which may be a good culture medium for infection. So those are the it's cheap, it's available, but you have to watch out for these possible complications.
Okay, very understandable. Dr. Brito, you have a question? Dr. Brito?
I have a question for Dr.
Okay.
Lagar. At what stage of a two-stage flexor tendon reconstruction? Yes, am I clear? Yeah. At what stage of a two-stage flexor tendon reconstruction do you decide to start fully reconstruction for cases where the flexor sheath has collapsed or already has unrecognizable polyp? Echo.
So when is the best time to do the reconstruction? Did I get it right?
Or when do you decide to do the reconstruction for pulley? Yes, for pulley reconstruction.
For pulley.
For pulley reconstruction.
I think the best time is after you have placed your silastic rod already, because more or less you would know how much tightening is needed for you to get a good space for your rod. So there will be a good fit, no? That is, if you know which particular tendon graft to use on your second stage. Because like, as I've mentioned in my lecture, if you're unsure whether you'll get the palmaris or your plantaris or the toe extensors, which are different caliber sizes, then it would be difficult. Another one is if you don't have the different sizes of the rod, even if you know that you'll use the palmaris longus and you have an idea of the size of the palmaris longus, but if what you have is smaller than that, then it wouldn't be also. Maybe you can loosen it a bit, but if it's big, then you will create a bigger lumen. I've had one case where on the second stage, I had a hard time passing the graft through this tunnel, and I had to make another incision just to do venting on the reconstructed sheath, flexor sheath, so I would be able to pass it. So that's just added time in surgery as well as stress for the surgeon. It turned out okay.
Thank you, Dr. Alagar. Now for Dr. Calleja, congratulations on on your published paper. But in this paper that you presented, you stated that only 69% of the patient population had their volar tilts restored. No? So can you comment on the apparent improvement noted in all patients of your patients patient population, regardless of volar tilt restoration?
Good afternoon, JJ, and good afternoon, everyone, to the speakers, my co-speakers, and Dr. Brito also. So I think because these patients came from severe deformities, such as 20 degrees to 30 degrees dorsal tilt, our parameter for normal volar tilt was normal to 10 degrees. So some of the patients were restored, or the volar tilt were decreased to about 5 or 10 degrees, but we accepted it already because we already had normal inclination in height. So even those, as you know, that kahit may konting dorsal tilt yan, they still function well. We didn't attain for maximum correction because I think yung goal for this paper, for this technique, is really to achieve a good height and inclination. And with those parameters, I really think this will improve. Imagine coming from 30 to 20 degrees and decreasing it to only 5 degrees.
Thank you, Dr. Calleja. Yes, Dr. Brito?
Yes, hi. Hi, Henry. Congratulations on your paper.
Hi, sir.
My question is, in your study that you mentioned, you were able to use a rectangular bone graft to bridge in or fill the gap once the destruction done for the malunion. So after the osteotomy, has there been any instance, that the distal osteotomy was at the level of the metaphyseal or cancellous area, where it's very soft? That what happens is that your graft could just telescope in, or it just goes in towards that distal area, that it's unable to maintain the height of your distal radius. Would you does this ever happen, or how do you address those problems?
For more chronic distal radius malunions, I don't think this is much of a problem, sir, because we can plan the osteotomy. For these types of distal radius malunions, you must chronic, sir. I make sure that the distal segment has space enough for the distal plate to fit in. So I cut it lower. I don't cut it at the fracture line, or basta I cut it para to accommodate the distal edge of the plate. I think this will be more of a problem if it's nascent, when yun hindi pa solid yung union ng malunion. So when you osteotomize it, you eventually end up, once you lift it, with a relatively
Malambot.
hollow distal segment.
Yeah.
So I just make sure that the lateral, medial, and anterior cortices is intact. I always tell my residents, when it's comminuted, you need not go for the comminution that much. You might further comminute the comminution in this distal radius malunions. So your goal is really to lift it up as one. And if ever there's a hollow area, as long as the cortices, anterior, lateral, medial cortices are intact, you can fill it up with bone graft and then support it with a plate. Just be careful. Yun lang. That's one point here to emphasize. Don't overly tweak the fragments when you have a distal radius malunion, because you might end up with several fragments that you cannot fix already.
Okay, thank you. I think we have some time now. We are quite a bit early before we go to the last presentation. We can accommodate one or two questions from the audience. We have one question about Wallant for Dr. Sibonga. So is there a role for Wallant, especially in extra-articular fractures of the distal radius, like doing procedures like close reduction and percutaneous pin fixation?
Yes, of course. Basically, the pain that is being given by the local anesthesia using the same principles of Wallant can help you with the reduction on extra-articular distal radius. You can get away with the epinephrine though, since you are not opening, you're doing close reduction. But by doing so, please to take note that the maximum dosage needed for the patient goes down to 5 milligrams per kilo without the epinephrine, meaning you can only give up to 3 carpules of lidocaine. So when you dilute this one with equal amounts of sterile water, you can only give up to 30 cc's of Wallant solution without the epi. And also, this will also help you, since you are giving lower amounts of Wallant solution, which works by tumescence. This can also help you without the with the reduction, because the area of the fracture line is not actually that swollen, which can affect a good reduction once you manipulate the fracture. So yes, you can do it even without the epi, just the Wallant solution without the epi.
Okay, thank you, Dr. Sibonga. So thank you to all our speakers for answering the different questions. And I think now we can proceed to the last part of the session. We have a case presentation from De La Salle University Medical Center, a case of another case of a Wallant procedure to be presented by a resident of the De La Salle University Medical Center, Dr. Kerwin de la Cruz. Thank you, everyone.
Welcome, everyone. I'm Dr. Kerwin Lester Y. de la Cruz. Welcome, everyone. I'm Dr. Kerwin Lester Y. de la Cruz, a first-year orthopedic resident from the De La Salle University Medical Center. Today, I'll be presenting a case entitled Segmental Forearm Fracture Fixation under Wallant Case Report. A 29-year-old male right-handed factory worker presented to our institution after landing on his outstretched hand during a motorcycle accident. There were no history of head trauma or other major injuries. He was conscious and able to walk to the emergency department himself. Pain over his right forearm prompted consult, and on physical examination, we noted gross deformity, swelling, abrasion, and a 2 cm and 1 cm laceration on the dorsal and ulnar aspect of his right forearm. Radiographs revealed a segmental fracture of the radius and an oblique fracture of the ulnar shaft. He was then advised open reduction and internal fixation. However, due to financial constraints and long waiting time for an elective OR slot, an option of doing the surgery under Walant as a daycare procedure was offered to him, in which he gladly agreed. So we prepared our Walant solution in a bowl by mixing 5 carpules of 2% lidocaine, making a total of 25 ml 2% lidocaine for analgesia. We then added 0.5 ml of 1:1000 epinephrine for hemostasis, 5 ml of 8.4% sodium bicarbonate to buffer the solution. "25 ml of normal saline, and then we added another 50 ml of normal saline, making a total of 105.5 ml Walant solution. This will make the preparation of 0.5% lidocaine with 1:200,000 epinephrine. For the radius, 30 ml of the solution was injected into the subcutaneous area of the plant incision and 30 ml on the subperiosteal area of the plant plate and pin placement. For the ulna, 20 ml of the solution was injected into the subcutaneous area and 20 ml on the subperiosteal area. As in the tumescent anesthesia technique, we injected the Walant solution until the soft tissue around the fracture site was covered. Adequate pain control was achieved immediately. And while waiting for the maximal vasoconstrictive effect of the epinephrine of approximately 25 to 30 minutes, we prepared and positioned the patient for surgery easily as he was conscious and could cooperate with us. We exposed the ulna via direct ulnar approach. The ulnar fracture was reduced and fixed with a 7-hole mini DCP. We then proceeded with the exposure of the radius via Henry approach. The radial shaft was divided into 4 fragments: a large distal ulnar fragment, a radial styloid fragment, a radial wedge shaft fragment, and a large proximal fragment. Fixation of the wedge fragment, large distal ulnar fragment, and large proximal fragment were done using 2 lug screws and 8-hole mini DCP. 2 K-wires were applied to secure the radial styloid fracture. The surgery went smoothly without any complications. Patient was then put on long arm splint. During the operation, the patient had adequate pain control and minimal bleeding of approximately 100 cc. He could interact and cooperate with the surgical team at any time. After the surgery, the patient was able to get up from the operating table immediately and was moved safely and comfortably. The patient was then discharged on the same day and was prescribed with oral antibiotics for 1 week and NSAID as needed. These are the radiographs 6 weeks post-op, before and after removal of pins. A video showing the range of motion at 6 weeks post-op. These are the images of range of motion of the right forearm in comparison to the uninjured side at 6 weeks post-op. From this case, we can say that fixation of segmental forearm fractures is safe and feasible under wide-awake local anesthesia, no tourniquet, or also known as Walant. Thank you and have a good day.
So I think we can. There's I think 5 minutes. No, okay. So we can wrap up with a few questions. Now for Dr. De La Cruz, I think Dr. Brito has a question for you.
Yeah, hi Kerwin, good afternoon. Very nice topic and case, no. In your procedure, how were you able to say that you've established enough periosteal infiltration of your wallet during your surgery? I would assume that the injection was done initially close. Then how would you say that you have enough periosteal infiltration of your anesthetic? Dr. De La Cruz? Can you hear me?
Yes, sir.
Hello? Kerwin? Can anyone hear me?
Yes,
Regarding the
yes,
question?
doctor. Dr. De La Cruz, did you hear the question?
Yes, sir.
Okay.
So how will you be able to say that you have enough periosteal infiltration?
Sir, we did prepare an extra solutions just in case there's still pain for the patient, sir. We can instill another
You can top up,
yes, sir. Opo.
you mean, no? But that's not without going beyond the maximum recommended dosage, right? The patient was not brought to the recovery room anymore. Is this correct?
Yes, sir.
So how was the patient after the procedure? No, usually Wallant wears off around 1 to 2 hours after this. And with this major surgery for ORIF of both radius and ulna, this is quite painful. How was the pain afterwards?
Sir, after the procedure, the patient did not complain of any pain right away, sir. That's why we discharged the patient on the same day. And then,
But this was how many hours after closing or after closure?
so around 1 to 2 hours, sir.
1 to 2
patient
hours.
was sent
Okay.
home with oral pain medication, sir.
Okay. Okay, thank you, Dr. De La Cruz. I think we have some question from our panelists, from our lecturer, from Dr. Calleja wants to ask a question to Dr. Alagar.
Hi, sir. Okay lang to ask a question, Dr. Alagar?
Yeah, go ahead.
So you mentioned earlier about the Paneva Holovich technique, sir. I've also done that technique, but I've always had problems with tensioning, sir.
Right.
So as you can see on the other technique, the palmaris longus, you attach it distally, then pull it for tension, then attach it to the proximal stump. But with the Paneva, you attach it distally, sir. There's always a fear na when you repair it na naka-extend yung finger, that there's not enough tension. So any pearls or tips on how to attach a Paneva Holovich technique?
I think what's important there is you have enough length of FDP attached to the distal phalanx. And I think this is best done under Wallant. So as you see in one of the slides, there's a video there where I temporarily attach the distal end of the graft just using a needle to temporarily hold it there. So once I've gotten the right tension, then I just support it. And you're right, it's kind of difficult to suture it. But if you have enough length of stump of the FDP, then there's more surface area to suture the graft to the stump. And the good thing about this is you can always ask the patient to kind of move his arm, and you have to so you get a better view of the graft that you are suturing. This is more challenging than the standard Hunter Salisbury technique. Yeah, and another problem I also notice in this technique is if you go beyond 2 months, it's so hard to release the adhesions in the loop. I don't know if you had that same problem, but if you've gone 3 or 4 months after that, it's so hard to release it. Yeah, I hope that helps, Henry.
Thank you, sir.
Thank you, Dr. Alagar. Maybe one last question. Dr. Alagar, what are your thoughts on single stage reconstruction versus the two stage? Is it less effective?
I actually saw that in the last webinar of Dr. Lalonde, and that is good. That is that is more cost efficient. No, you just have to create the A2 pulley and just put the graft on top of the rest of the pulley. And I probably start trying that. I haven't done that, but I will surely try that. Thank you. Thank you for that question, Jake.
Okay. Thank you, everyone. I think time's up. So we're just on time for our session. So I'd like to thank everyone, our speakers, Dr. Sibonga, Dr. Alagar, Dr. Calya, Dr. De La Cruz, and my co-moderator, Dr. Brito. Again, on behalf of the Association of Hand Surgeons of the Philippines, thank you, everyone, for watching this session. Thank you and
Don't
good
forget to
afternoon.
vote.
Oh, yes. Dr. Alagar?
Yes.
Don't
Ano?
forget to vote.
Oh,
We will,
yes. Everyone, please vote through the Phil Ortho app.
Vote.
Okay, the POA app. Don't forget, it will be closed by 6 p.m. tonight. So thank you, everyone, again, and have a nice day, everyone.
Thank
Bye.
you, everyone.
Thank you.
Thank you to the speakers of the Association of the Hand Surgeons of the Philippines.